all antenatal profile. Got it. So in a low risk patient. So that is one thing. And now say live. Nisha, are we live?
Ma'am, 1 second.
बबीता कुछ स्क्रीनशॉट लेते हैं ना whenever you get the
ले
time
रहे, ma'am, ले रहे, ले
do
चुके हैं।
screenshot. Yes.
Ma'am, should we start?
निशा
Nisha?
Yes, yes.
निशा ने कहा ना भी एक
Ma'am, 1 minute, 1 minute.
Okay, fine.
हम 1 घंटा में तुमको फोन करेंगे चुन्नू। अच्छा ना, अभी वेबिनार में है।
showing Nisha live on YouTube. What is some issue, technical issue?
No, ma'am, it is sorted now. We are live now, ma'am. We can start the event.
Good evening, everybody. On behalf of the Gorakpur Chapter of ISOPARB and Gorakpur Obs Gyn Society, I welcome you all to this wonderful webinar studied with jewels and gems from the field of obstetrics and gynecology. The topics today are based on the antenatal care. The more we talk about it, the more we realize that we know much less. And every time there is something new to learn. So again, a Pandora's box is going to open today. And let's see what we have. We have with us Dr. Usha Sharma, Madam, the President, ISOPARB National Body, as our chief guest. Dr. Gangadhar Sahu, President-elect, as the guest of honor. And Dr. Deepika Dekka as the special guest. Before starting this program, let's invoke Lord Ganesha and start this meeting with a prayer.
Vakratunda Mahakaya Suryakoti Samaprabha Nirvighnam Kuru me Deva Sarvakaryeshu Sarvada.
At the outset, I would love to call upon Dr. Sadhna Gupta, ma'am, who is the President of Gorakpur Chapter of ISOPARB, for her welcome address. Madam is a well-known personality for her academics, depth of knowledge, and organizational capabilities. She is righteous, honest, generous, and dedicated, a true leader. Over to you, ma'am, for your welcome address.
Thank you, Amrita, for your loving words. And first of all, very good evening to everybody on the eve of Republic Day. And we are rightly here for like having the few carry home points for all our 27 million women who we cater every year as an obstetrician and gynecologist. So a very happy Republic Day to all. And I welcome everybody on the board who are with us on this evening, on this important evening. And my warm welcome to President Dr. Usha Sharma of ISOPARB, and who has been generous enough to give her full-hearted support to newly born Gorakhpur chapter. And we are so fortunate that we could organize an international hybrid conference of its own kind in her leadership just on last November. It is the first meeting of this year, and it is the first meeting after the conference we have. A hearty welcome with a sincere regards to Dr. Gangadhar Sahu, who is the president-elect of ISOPARB this year, but he's a real philosopher, learner, teacher, and we always get his philosophical message, and sometimes it seems like it is a God sent in that particular moment. So we are very fortunate to have people and person and the human being like Dr. Gangadhar Sahu with us, who guides us not only with his academic excellence, with his experience, but the way we should see the life as a human being on the many platforms. Dr. Deepika Dekka, what to say about her? A very old friend, and she had raised the flag for fetal medicine in India when the people were not aware about this specialty. And we were very happy then our society organized North Zone Yuva Foxy in 2010, and she delivered our first oration in the name of Dr. J.R. Khudaiji. And we had that close bond from since years, and now we have been walked together in the Foxy, and we have walked together in many platforms. So a warm welcome to chief guest of honor and the special guest, and we are really like to hear from you after formal introduction. About the panel, Dr. Pranjal Saraswat was the key thing because she was co-moderator. This panel was scheduled for Indore AICOG. But you know what makes us going? The young people with their enthusiasm, with their keenness, with their vibrancy, they kept us looking. They are the put to accelerator, and we said that no, we had so much of discussion on this panel, and we should not lose this panel. So thank you very much, and all the panelists who are with us today, Manjula, Dr. Usha, Dr. Sudha, Dr. Ritu, Dr. Manisha Ghate, Dr. Preeti Gupta, Dr. Bharti Swarankar, and we are going to have a wonderful panel, and we will have very clinical and down to earth discussion on the optimizing antenatal care, which is one of the very important keystone in the SDG goal, that is reaching equal effective care to all women. So this is all about, as a president of Gorakhpur chapter of ISOPARB, as well as a member of Gorakpur Obs Gyn Society, it is a pride that I am welcoming you on this evening on this important webinar. Thank you very much for accepting our invitation despite your always busy schedule. So many things, Dr. Deepika, Dr. Usha Sharma has just had a marriage in the home, and this shows actually commitment and dedication that we all are joined through the same thread of professionalism and our duties towards the women of our country. So thank you very much. And Amrita, over to you to the further proceeding and the introduction of chief guest and guest of honor.
Yes.
Thank you.
Thank you, ma'am. Thank you for the opportunity given to me. So our chief guest is none other than Dr. Usha Sharma, a very dedicated and sincere person. And she's such a big personality, president of national body of ISOPARB, and so much down to earth. And as Sadhana Gupta ma'am rightly said, that she was there in the marriage. And in the morning, she gave me a call that I'll be present there for the meeting. So this shows the kind of dedication she has for her jobs which are allotted to her. Thank you, ma'am, for being with us. Madam is the National President ISOPARB. She is a senior consultant obstetrics and gynecology, SK Memorial Hospital and AK Memorial Nursing Home, Patna. She is honorary consultant of Red Cross Polyclinic, Patna. She has been the she is also the advisor of Safe Motherhood Committee at Patna Obs Gyn Society and has presented many papers at FOXI, ISOPARB, RCOG and other societies, contributed chapters in FOXI publications, and she has been the former East Zone Fellow Representative of RCOG. She has also held many positions in ISOPARB, like being the General Secretary and the Vice President in the past. Over to you, ma'am. We would like to hear from you and get your blessings. We seek your blessings.
Now you all can hear me?
Yes, ma'am.
Hello?
Yes, ma'am.
First of all, thank you for inviting me. My best wishes to Dr. Sadhana Gupta, an academician, and all the things I was going to say, Amrita, you have said it about her, so I won't repeat it. I add to it, great clinician for her candidature for FOXI president. Today's program provides all the attendees an opportunity to take some very important clues in the panel, 9 month, 9 problem, and 9 solutions. I am eager and looking forward to our special guest, Dr. Deepika Dekka's talk on when to consult a fetal medicine specialist. As you all know, she is a pioneer in the field of fetal medicine. My special welcome to Dr. Gangadhar Sahu, a very learned and inspirational figure, soon to lead ISOPARB as president. I am happy to see Dr. Radha Jina and Dr. Reena Srivastav, who are guiding GOGS in a brilliant manner. I appreciate the dynamic and efficient Dr. Amrita Jaipuriyar, who is the secretary of ISOPARB and is going to be president of GOGS of Gorakpur Obs Gyn Society, along with other office bearers of GOGS for organizing today's webinar. My best wishes to Dr. Pranjal Sharma, the co-moderator, and all the esteemed panelists. Happy learning and updating knowledge. Long live ISOPARB.
Thank you, ma'am. Thank you for your kind words. Our guest of honor is Dr. Gangadhar Sahu. Sir is a retired professor and head of the Department of Obs Gyn Society, VSS Medical College, Burla, Sambalpur. He's been the Dean, IMS, and some hospital, Bhubaneswar. He's a pro VC SOA deemed to be university. President-elect ISOPARB 22-23. The sir, other than being a great teacher, has many great qualities, and every morning I get a wonderful message from him. He's an inspiring person, very inspirational messages he sends. And we can see the last line, what is his dream? He dreams to be a ladder for others to climb to the top. This shows his humbleness and greatness of his personality. Over to you, sir, for your blessings.
Thank you, Amrita. My namaskar to one and all who are present here, including the great Sadhana Madam. So I feel so homely now that as if I am a part and parcel of your chapter, that is Gorakpur ISOPARB chapter. So I have mixed almost I am in contact with you, Sadhana Madam, almost daily morning, and as if I am talking to you. So thank you for inviting me for this occasion as the guest of honor, I feel honored. So regarding today's your seminar, I will say that you have chosen a topic on fetal medicine, when to consult and how to consult. So I felt that it is very funny. So how to consult? I mean, is it offline or online? When to consult? When Deepika madam is free in her chamber. So therefore, I am waiting for that answer. So regarding 9, 9 and 9. So how did you, Amrita, select this 9, 9 and 9? Now, till now, I am thinking.
Sadhana ma'am's baby, ma'am, sir.
So Sadhana ma'am's baby, grandbaby or grandbaby, whatever it may be. Anyway, so nice. So when I saw your flyer, I could understand that it is a multiplier of that 9. 9 into 2 is 18. 18 plus 1 is 19. There are 19 photographs. I don't know whether you have counted or not, Amrita. So 18 are galaxy of twinkling stars. And one is this person, Gangadhar Sahu, the moon. So then I decided most probably that 9 and 9, 19. So then it starts with 9, 9 and 9. This number 9, madam, it has got some mythological and historical links. Mythological in the sense, Navaratra, that is 9. So then we call it Navaratna from Bhatri Singhasan of Vikramaditya. So therefore, definitely the discussion will give us some solutions from the 9 problems you have thought in 9 months, and the 9 problems and 9 solutions. I am waiting for this wonderful panel discussion which is going to happen, and a talk much cherished regarding fetal medicine by Professor Dekka. So with this, greetings from Bhubaneswar, blessings from Lord Jagannath and Baba Lingaraj and Suryadev and Ma Samaleshwari from Sambalpur. I thank you once again, Amrita madam and Sadhana madam, Babita madam, and all of your members of Gorakpur Obs Gyn Society and ISOPARB for inviting me for this today's occasion. Thank you very much. Namaskar once again.
Thank you so much, sir, for your wonderful, witty words. Now we come to our clinical session. And before starting the clinical meeting, let's call upon Nisha. Please show us the lightening of lamp, because light is the source of knowledge, energy, and everything what we have around. Fetal medicine is dedicated to managing unborn babies, and fetal medicine expert possesses the capability of doing this. It needs advanced knowledge of obstetrics, medical, genetic, and surgical complications of pregnancy, and the effects of these complications of mother, fetus, and the newborn. So for this, we have none other than Dr. Deepika Dekar, who is our speaker. And to start this session, I would like
And
to
she is a
invite,
special guest also.
and she is the special guest. Yes, I
Yes,
mentioned
she
it
is.
in my opening remarks. So I would like to call upon the chairpersons for this session, Madam Radhajana and Dr. Reena Srivastav. Madam Radhajana has been conferred with UP Ratna Award lately. Congratulations to you, ma'am.
Thank you.
And we all know she is our great teacher, and she needs no introduction for the Gorakpur Society, but she is a retired professor, BRD Medical College, Gorakhpur, has more than 100 papers in national and regional conferences, presented many papers, and like she has got them published also in various journals. She has been the past president of Gorakpur Obs Gyn Society. She has also led the UPCOG. She has been the president of UPCOG in 2016, organized various conferences, and has been felicitated by many awards. And the latest one is the UP Ratna Award. Welcome to you, ma'am, on this platform. Our second chairperson is Professor Reena Srivastav. She has been ex-professor and head of the department Gynae Obs, BRD Medical College, Gorakhpur. Even she has led the UP chapter of Obs and Gynae. She has been the president, Gorakpur Menopause Society, president of Gorakpur Obs and Gynae Society, held many conferences, organized many workshops. To name a few, UPCOG, North Zone UA, FOXY, SAFOG, and also the last ISOPARB Gorakhpur Chapter, which was there in November. And she has many publications in national and international journals, and has been felicitated by many organizations, local and at national levels. So over to you, chairpersons, for the session.
Thank you, Amrita. Nice. Good evening, everybody. Now, thank you, Amrita, for your nice words. Now it's my pleasure to chair this important webinar today on when and how to consult fetal medicine specialist. Now, this topic selected is very important, and we all have to consult maternal and fetal medicine specialist off and on. A maternal fetal medicine specialist is one who helps to take care of women having an complicated or high-risk pregnancy, and they are the obstetricians with 3 extra years of training in high-risk pregnancy. Now, woman is referred to fetal medicine expert when an abnormality is detected during routine ultrasound, or there is concern about the well-being of an unborn child or a woman who has bad obstetrical history. Now, today it's my pleasure to introduce Dr. Deepika Dekar, who is a speaker and special guest for today's webinar. Now, she is a senior consultant, fetal medicine and genetics, Cloud Hospital, Gurgaon. She is president, Delhi Gynecological
Isha, please flash the CV of Dr. Deepika Dekar.
Forum, Dwarika, and she was former professor and unit head Obs and Gynae, Chief Maternal Fetal Medicine, AIIMS New Delhi, and Vice Chancellor, SS University of Health Sciences, Government of Assam. He was director of AIIMS Kalyani, Kolkata, West Bengal.
Nisha, please flash the CV.
Now, she was past president. Yeah, I got the CV. She was past president, Society of Fetal Medicine, past chairman, Genetics and Fetal Medicine Committee, FOXY, and past chairman, ISOPARB North Zone. She had more than 258 national and international publications to her credit, and more than 60 chapters in various books. She has given various plenary lectures, more than 600 paper presentations in maternal and national and international conferences. And she has a long list of awards, and few important ones I am going to narrate are ISOPARB Kamla Achari Award 2000, Dr. S.K. Bhandari Gold Medal 2002, Asia Oceania Young Scientist Award 2004, C.L. Jhaveri Award 1992 and 2009, and C.S. Down Award 1994, 2000 and 2010, and many more. So now I invite Dr. Deepika for her presentation. Over to you, Dr. Deepika.
Namaskar. A very good evening to all the dignitaries present here. First of all, I would like to thank Dr. Sadhna Gupta for inviting me, not only today, but so many times. And as she said, for the first oration in the Yuva Foxy, which I really enjoyed going to Gorakpur, seeing the new city, visiting the places of importance there. Then I must, yes, so nice to see Dr. Usha Sharma. Namaskar, madam, and for being also the president of the ISOPARB. We have been working very close together for decades. Dr. Gangadhar Sahu, congratulations on going to be taking over as the next president, and everybody else, otherwise it will become very long. So I really thank Sadhna for inviting me to talk on a topic which I think is very relevant today. A lot of obstetricians, they try to take the decisions. Many of the decisions can be taken by them, but sometimes there can be problems in difficult cases, and that is where a trained person is necessary very often. So I would like to share my screen. And the topic, is my slide visible now? Is my slide visible?
No, only your
No,
screen,
no,
ma'am.
no, not
Only your screen.
wait. Your
Ma'am,
laptop
you-
is saying.
Now you have to get into the
I
presentation.
already
Get
did
into the
it.
presentation.
I don't know why it's not coming.
Ma'am, you have, once you
Click over
stop
it.
sharing the screen.
Is it
Ah,
there?
yes,
Yeah,
yes,
yeah,
yes.
yeah, yeah.
Okay, now I'm
you're
making it.
Full
Big.
screen.
Yes, yes.
Right.
It's coming?
Done.
Okay,
Yes.
okay.
Coming.
Yeah, I'm working in Cloud9 Hospital. It's basically it's a different mother and child hospital only, and I'm getting a lot of scope to work on fetal medicine. That's why I'm very happy here. So let me go straight to the point. You all are obstetricians, and you have a very, very important responsibility, because obstetrics is changing every day by progressing by leaps and bounds. And it is very difficult for the obstetrician to keep pace with the recent advances. Latest screening, diagnostic techniques, basically the interpretation is the problem. Just now, while I was sitting here, I got a message that there is a down screening of 1 in 5,000 something, and they are worried that the 5,000 is the problem, whereas it is the other way around. We are blessed that we have to look after 2 patients, not 1. So now the baby is not an appendage of the mother. You know, the baby has been given a status of an individual person. What is the difference between an obstetrician and a fetal medicine specialist? Obstetricians, besides normal labor, normal pregnancy, which is very, very exciting, you also have to sometimes deal with maternal disorders, complications like preeclampsia, DDM, APH, etc. But now with the newer, lifestyle changes, increasing age of marriage, I'm very surprised that in Cloud9, the mean age of having a baby is like 37, 38, as if that is the youngest age someone is having a baby. Moreover, there are nuclear families. Everybody wants their just 1 or 2 children, should be most intelligent, should be most active. People are also aware, they are aware of their rights. And very often, if by chance a baby turns out to be having a genetic defect, then the obstetrician can be sued. And all these things, earlier on, babies were dying because of malnutrition and other things. But now congenital malformations, genetic diseases are becoming more and more important. And this has given birth to a new subspecialty called maternal fetal medicine. Timely referral by a general obstetrician to the fetal medicine specialist can go a long way in improving the maternal as well as the fetal outcome. Because we can tell you about the appropriate time for screening, which is the best time for referral, the accurate diagnosis, and of course the management. And this is earliest identification of risk factors can even be made preconceptional. And this is very, very critical for the best maternal and the fetal outcome. So who is a fetal medicine specialist? This is a team, but the team leader is the obstetrician who has had some more qualifications, as you have said, formal training in fetal medicine and genetics, advanced knowledge of what are the congenital abnormalities, the various more than 4,000 genetic disorders that can occur in the fetus. We also have intensive training and experience and skill in very fine, sophisticated procedures of prenatal diagnosis on a very tiny fetus, 11 weeks fetus. Therapeutic procedures like intrauterine transfusion in a 500 grams baby. So, plus we have to look after the mother who is carrying the ill fetus. So this is a very specialized and a skill requiring specialty. We all love this type of a pink healthy baby crying, but sometimes we have a nightmare. This is a baby with heart disease. This is a child with Down syndrome. The beautiful child in the center is sleeping with blood transfusion going in because the child has thalassemia major. And Dr. I.C. Verma, who is one of the pioneers in genetics and a renowned figure in the world, his data showed that 2 to 5% of every pregnancy, there is a risk of a congenital malformation, and this can occur in low risk group. It doesn't always happen to be a mother with a high risk factor. 90% of malformations occur in women with no risk. Chromosomal abnormalities, a very large percentage occurs in women above the age of 35, but 80% occur in women who are 20, 30 years old. Then we have a very large chunk of single gene disorders and other genetic disorders like beta thalassemia, spinomuscular dystrophy, Duchenne's muscular dystrophy, sickle cell disease, and so on. They're all together clubbed as birth defects. The birth defect is defined as a structural functional anomaly, hereditary disorders which occur during intrauterine life. Unfortunately, they are identified only after birth or later in life earlier. I did this study long time back at AIMS in 2006, and we found that though the people obstetricians were aware that these are some conditions, genetic conditions, not many were aware that we can prevent thalassemia, prevent Down syndrome. The commonest diseases, this one is mental retardation. This picture on the right side, this is a family with all 3 children having Down syndrome. This little baby and this boy, both of them are same age, but he is looking younger because his growth is stunted. He's getting blood transfusion. How can a small child not play? But if this child plays, he has hemophilia B. So then his body starts bleeding and he needs blood transfusion. So what is his life like? Then we have this boy with very thick muscles, but he cannot walk because he has Duchenne's muscular dystrophy, osteogenesis imperfecta. So all these things we can prevent. Then we have the second commonest cause of mental retardation in males, the Fragile X syndrome. These are lethal skin disorders, epidermolysis bullosa. This child is living but will die very soon because this blebs, and this is just a skin lesion. Then we also have maternal conditions like this baby of a diabetic mother. will have 7 to 10% increased chance of a congenital malformation. We have a large number of women who come who have taken warfarin during pregnancy, but the babies can land up with a very flat nose, even breathing problems, warfarin embryopathy. Then, of course, the commonest condition, of spinal defects, spina bifida, anencephaly, these can be so easily prevented. Then my favorite topic, rhesus isomnization, hydrops fetalis, and of course, this congenital infections, congenital rubella syndrome. This child has keratopathy because of the rubella and is going to be born blind. Fortunately, we don't see much of syphilis or much of goiters anymore. Then we have nowadays so many cases of ART, and these are again very high risk pregnancies. There is increased risk of malformations in such cases. This was one of our babies on warfarin, and we had to intubate the child because the nose was so blocked, the child could not breathe. So just a few of the cases that I showed, is it right that in today's century, today's era, we have babies born with handicap? They are a major cause of mental, social, and economic burden of a preventable condition. Let's see how. So life begins at conception and not after birth. We have to understand that. In fact, I think it begins pre-conception, because the ovum is there and the sperm. There can be so many conditions, and they can cause medical legal issues also. So the specialized care of the fetuses at higher risk of chromosomal malformations and infections, syndromes, and are now IUGR and pre-eclampsia are also included in fetal medicine. And this field is very rapidly increasing. We are a team. The obstetrician looking after the high-risk woman carrying the ill fetus is a very important member of the team. The fetal medicine is the referral specialist. Then we have, the genetic laboratories, the ultrasonologists, MRI, and the pediatricians. The important part is the group, thalassemia, hemophilia societies, and so on. So what is the role of the obstetrician? Obstetricians nowadays need to know how to take a good history, a 3-generation history, family history, and they must know that you have to screen all pregnant women, not just high risk. For malformations, chromosomal abnormalities, you are the first line who will meet the pregnant woman, and you have to know when to consult a specialist. Timely referral to fetal medicine specialist is very, very important. And when the treatment is done by the fetal medicine specialist, the rest of the pregnancy has to be continued in collaboration with the obstetrician and the fetal medicine specialist as a team. So coming back to my topic with this background, let us see when we need really to send the patient to the fetal medicine specialist. So who is that? Is a person who has advanced genetics knowledge, fetal medicine knowledge, skill in procedures like ultrasound, invasive procedures like amniocentesis, CVS, cord blood sampling. Then they also need to be trained in fetal therapy, which could be medical or surgical. And most importantly, because this is a very rapidly advancing field, we are doing a lot of research, innovations, how to improve fetal treatment, pre-implantation genetic diagnosis, and so on. What is genetic counseling? To begin with, this is the identification of a high-risk group of women who have to be told about what is the risk, how to pick up the risk, and how to manage. Now, at various points of referral, starting from preconception, maternal age above 35 years, family history of genetic disease. Just today, I got a very interesting case of maple syrup urine disease. And now the patient is telling me that her uncle's son also had it. And they were hiding the disease, from the rest of the family. They should actually have told everybody to get tested Instead, they were hiding. And now this baby is born and died in 2 months. Then we do pre-pregnancy screening for thalassemia, hemoglobin, sickle cell, and pregnancy, with previous babies being dead, malformations. And of course, if a woman has been exposed to teratogen, we used to get a lot of infertility patients conceiving on the same month that they had a histosalpingogram or an X-ray. We all know that the increasing age, there is higher risk of chromosomal abnormalities. And then we are all doing, early pregnancy screening. We need to do combined screening test, which will also screen malformations like neural tube defects. We are also doing things like non-invasive prenatal testing, torch screening, and then of course, complicated twin pregnancy. Then you find that very high TSH values. We are every day screening for TSH. And I get a lot of cases, TSH is 75, 80, and the mothers want to know, should we terminate the baby pregnancy because the baby is going to be mentally retarded? So is it correct? That is when you need to talk to a specialized person. Then you have a structural malformation detected. Those are cases which definitely need some intervention. Not all malformations should be aborted. Then some of them may land up with problems if you don't do something. So there is a role of a fetal surgery. Then we have cases of RH isomerization and high-risk pregnancies. Now, recurrent miscarriages is another group where we are consulted, especially if there is blighted ovum and repeated miscarriage, missed abortions. There could be chromosomal problems in the parents. When do you need us in mid-pregnancy? When there is a first screen, if not screen in the first trimester, you are doing a quadruple screen in the second trimester. I purposely cut the triple marker test screen because we should not do that anymore. We have quadruple marker and we have NIPT in case you're late. Especially NIPT, of course, non-invasive prenatal testing has a lot of indications. Then there are structural malformations which were not detected earlier, are detected in the 18-week scan. And then you can also diagnose syndromes. Now, what is a syndrome? A syndrome is a condition which can have a hereditary. More than 3 things are present in all, like Charcot-Levin syndrome, Engelmann syndrome, Prader-Willi, Rett, and so on. So these are conditions that need expert advice. Biochemical screening should be part of every patient's antenatal care. And of course, ultrasound screening in the first trimester, the 11 to 13-week scan. This is a slide which I just made for, easy reference, that in the first trimester, double marker test, and then 11 to 13 weeks ultrasound screening for aneuploidy. Now here is a new addition, screening for preeclampsia, IUGR, and preterm birth. So we do that in the first trimester and we can predict and prevent. The quadruple marker is done at 16 weeks, and the ultrasound is done at 18 weeks, not 20 weeks, for malformations and aneuploidy. At this time, we again screen for preeclampsia, preterm birth, if necessary, fetal echo. So preeclampsia, preterm birth, and IUGR is important components. And we do the maternal characteristics, we do Doppler of the uterine arteries, and if necessary, we start them on treatment with aspirin or whatever. Ultrasound screening and aneuploidy for malformations, the traditional 11 to 13 plus week scan. This was a case of Turner syndrome that we detected very early. Again, another bladder, obstruction. So we can very nicely see the spine and all movements. And we can also look at nuchal translucency, nasal bone. Second trimester malformations we have been doing for years, and this is to be continued. 3-dimensional, 4-dimensional ultrasound can really make you look at the fetus before it is born so accurately. And then we have a new thing called soft markers. These are not what we generally look at. These are some things that we have to search for in the high-risk cases or if there is any problem in the baby, especially defects. when we have a malformation, major fetal malformation, and somebody wants to carry on with the pregnancy for neonatal care surgery, we must exclude a chromosomal abnormality, which can be very high in cases of cardiac defects, diaphragmatic hernia, duodenal atresia, and so on. And then comes the forte of the fetal medicine specialist. This is amniocentesis, chorion villus sampling, where we are taking the villi and cord blood sampling, where we can take the blood. The various indications for amniocentesis are now mainly is the diagnosis of biochemical screen positive for chromosomal analysis. Then chorion villus sampling is basically done for conditions where we need DNA for thalassemia and so on. And of course, this is a data of in long time, 2012, 1,342 cases of cord blood sampling, where of course RH hybridization was a very big chunk, but we also did it for malformations, chromosomes, thalassemia, hemophilia, and so on. Now, there are lots of conditions where we may have problems. This is with the guru of fetal medicine, Professor Kypros Nikolaidis, when he came to AIIMS for a FOXY conference. And very important is operator experience and training. And that is why the fetal medicine specialist who is trained well is very, very important. Rhesus isomerization, you have to give blood transfusion to a baby which is hardly 400, 500 grams, needs a lot of skill. And of course, very happy that with improving, CMEs like this, we used to get a lot of cases referred to us with hydrops, and now that has decreased. And with transfusions, I'm very proud of this slide, where I must say that with our cases and experience, our aim of saving the babies with RH hybridization is almost in the range of 90-93%, especially if they are non-hydropic, and on better than most of the centers in the world. Then we are skilled in fetal surgery. When you think that we need to do image-guided surgery or fetal endoscopy, like here we can do occlusion of the cord. Then here we are doing vesicoamniotic shunt in a case where there is bladder outlet obstruction, or pleuroamniotic shunt. Fetal endoscopy, this is one of my pictures where we do actually do a TTTS, we can treat, and that gives the best prognosis. This was published in the Journal of Obs Gyn of India. And we had started fetal medicine endoscopy way back in 2010. But these they have some complications, and therefore we have to be very, very skilled. And lastly, the newborn. So we may have to deliver the newborn by an exit procedure, which is ex utero intrapartum treatment, where the placenta works as a heart-lung machine, and especially in cases of neck masses. And finally, research in fetal medicine has to go on, especially for the treatment of spina bifida, special surgeries, endoscopically. Then I was doing a lot of work on stem cells, which, is where the baby fetus is very rich in stem cells, mesenchymal stem cells, hematopoietic stem cells. And therefore, to conclude, fetal medicine specialists are very useful to obstetricians in the new 21st century state-of-the-art obstetrics and perinatology. Thank you all very much.
Thank you, Dr. Deepika.
I hope I have stuck to my time. And because of the shortage of 10-12 minutes given to me, I have not shown videos. So maybe some other day. Thank you very much.
Thank you, Dr. Deepika, for such a nice and crisp message to the journalists, to the obstetricians. What they should actually, they have got double responsibility. They have to treat the normal antenatals, and as well as they have to screen out the bad obstetrical history and the various chromosomal anomalies and structural anomalies. They have to be vigilant for it. Otherwise, how to refer to a fetal specialist? So the basic thing is to know what they have to do at the grassroots level, not only giving iron, calcium, and tetraad, but they have to look into the patient to her history, to her medical status, and if at all there is a bad obstetrical history, if at all there is IUGR in the past, whatever obstetrical history she is going to, we have to be very, very vigilant, and accordingly we have to submit the patient to the investigation. Sometimes people say it is a very long list of investigations. Why so? And if anything goes wrong, then the sword will on our heads. So we have to be very vigilant in which patient we have to give a battery of tests to know what abnormality is there. And if at all it is there, we have to shift the patient timely to a fetal medicine specialist, because the counseling part you cannot do if you don't know. So the knowledge of each and everything, which patient to be submitted where and how to what investigations, is the root thing which any antenatal patient will require from us. So the journalist or any obstetrician has to be vigilant for it, and very nicely you have given the list of diseases where and what is required from us. So I think the delegates must have got a very good message from your lecture. Thank you, Deepika. You have been wonderful in your presentation.
Thank you.
Thank you, Deepika ma'am. It was indeed great to hear from you, and it was a wonderful talk, and we would love to have you once again for your videos.
Anytime.
Yes, ma'am, we would love to have you.
Can I make a comment?
Yes, ma'am.
Dr. Deka, I am so proud to hear your talk, because the theme I have kept for ISOPARB during my tenure is say no to birth defects.
Yes.
And you have endorsed that I have done the right thing.
Yes.
Ma'am, Gina, Madam Gina, do you want to say something? Gina, ma'am?
Yeah, it was a wonderful talk. And I was so much excited to hear Dr. Deepika. And it was really a wonderful talk, up to the mark, above the mark, I can say. I have heard so much about you. Thank you.
We have met many times.
Yes, ma'am, we have met.
In the conferences.
Yeah.
Yes.
Yes, ma'am. Even in the cruise, 2008. Yes, ma'am. We were there.
Yeah.
Yes, ma'am.
Thank you so much, Dr.
Thank you so much for inviting me.
Thank you, Deepika ma'am. Thank you, chairpersons, Madam Gina. Thank you, Madam Reena Srivastava. So we quickly move on to the second part of the clinical meeting, that is the panel discussion being moderated by Dr. Sadhana Gupta herself and Dr. Pranjal. And for the proceedings, I hand over the platform to Dr. Babita Shukla. Over to you, Babita.
Thank you, Amrita ji. Good evening, everyone. After such an interesting talk, let's take a step forward and move to an even more interesting topic of our panel, 9 months, 9 problems, and 9 solutions. As Dr. Gangadhar Sahu sir has said, it is the number 9 is associated with our mythology. Let's see what we reveal today. And for this interesting panel, I would like to invite the moderator, Dr. Sadhana Gupta ma'am. I have read your CV so many times that it is on the tips of my finger. I will not go in for formal introduction, but yes, a very bright academic career, recipient of several awards and several publications, presentation, organizing so many conferences. But what I would like to emphasize is, we know her as a sincere, hardworking, and diligent lady. She has a bright academic career and has received several awards. A lady with a smile, yet firm decision. She is a born leader. A leader is one who knows the way, who shows the way, and leads the way. We are very thankful to Sadhana Madam for leading us to such great heights, and we all hope to see her as president of Foxy this year. Now, a second chairperson, Dr. Pranjal Sashwat Sharma. She is senior consultant, Amravati, organizing secretary of AMOX 2020 and Journal Conference 2017. She's Vice Chairperson, PCPNDT State IMA 2018-19, Chairperson of Beti Bachao, Beti Padhao State IMA 2019 and 20, Zonal Coordinator Zone 6 EMOGS 2018-20 to 2022, and Organizing Chairperson Adolescent Zonal Conference EMOGS. I would also like to introduce our esteemed panelist, Dr. Sudha TR is Professor and Head of the Department, Obs and Gynae, Hassan Institute of Medical Sciences, Karnataka. She is UPPG GNMC Belgaon Fellowship by Indian College of Obs and Gynae, Assessor MCI, RG UHS PhD Obs and Gynae, invited faculty and chairperson in Zonal National International Conferences, faculty for Obstetric Protocols National Committee, reviewer of International Journal, and reviewer of GOI Guidelines and ISUD Manual, recipient of several awards, and she's examiner in for undergraduates and postgraduate and has presented many papers. Second panel, warm welcome to you, Dr. Sudha TR.
Thank you, ma'am.
Our second panelist, please move the slide, Dr. Bharti Swankar. She is an obstetrician and gynecologist from Indore, Madhya Pradesh. We just missed the conference of Indore, hoping to be there very soon. Warm welcome, Dr. Bharti. We have Dr. Manjula Rao, who is Senior Consultant and HOD, Obstetrician and Gynecology Department, HOD Obstetrician and OB-GYN Department, Durgabai Deshmukh Hospital, Vidyanagar, Hyderabad. A warm welcome, Dr. Manjula Rao.
Thank you so much. Thank you. It's a pleasure to be here. Thank you.
Then we have Dr. Vaishali Jain. She's Assistant Professor at MGM-MC and MYH Indore. Her area of interest being high-risk obs, gynae ultrasound and endoscopic surgeries. She's a gold medalist during MBBS and has many publications in national and international journals. She has also received the Best Poster Award in National Cervical Pathology Conference. Warm welcome, Dr. Vaishali.
Thank you, ma'am.
Then we have Dr. Preeti Gupta. I hope she has joined. I've been trying to call her so many times. She is Director, Lakshman Seth Hospital and IVF Center and Lakshman Seth Group of Institutions, Jhansi, Uttar Pradesh. Warm welcome, Dr. Preeti. Are you there?
Preeti is running with some cold and cough. She said, if possible, she'll join.
Okay. So next we have Dr. Manisha. Please say, She is West Zone Coordinator, Food, Drug, Medico-Surgical Equipment Committee, FOXY, Chairperson, Women Doctors Wing, Secretary of Chandrapur Obs Gyn Society, Vice President, IMA Chandrapur, Director of Chandrapur Test Tube Baby Center, and invited faculty in national and international conferences. Her area of interest being laparoscopy, infertility, and colposcopy. Warm welcome, Dr. Manisha.
Thank you so much, madam, for the kind introduction.
And now I would like to introduce my junior, Dr. Ritu Srivastav. She is Director and Consultant OBGN at Savitri Clinic and Research Center, recipient of gold medals in undergraduate and postgraduate and publications in Asian Journal of Medical Sciences, International Journal of Medicine and Public Health, and New Journal of OBGN. Warm welcome, Ritu. Now I hand over this virtual dice to our moderators, Dr. Sadhna ma'am and Dr. Pranjal.
Thank you, Babita, for wonderful introduction. And let me share the screen. Slides are visible?
Yes,
No,
ma'am.
not yet.
Screen sharing is
Not
started.
Not yet visible.
Yes,
Now it is visible, ma'am.
So thank you very much, and all welcome once again as a President Gorakpur Chapter of ISOPARB and like as a moderator. So we had a wonderful talk by Dr. Deepika Dekar that what is the role of fetal medicine specialist and how we can collaborate with the expert And in this panel, we will say that what usual problems we are having. Our patients are having many problems, and the obstetricians are also having a lot of problems, because sometimes they get too much, it's like confused that what to do, and the patient is also confused, because it is a very common scenario that the patient is coming and going from this doctor to that doctor with taking few reports and few ultrasound, and they hope with the wonderful panel right from pan India, south, north, east, west, from the young to the senior teachers and the stalwarts, I think we will have few like clear message for the complex situation. So I bring greetings from many organizations, and it was Omnicon, which the panel was scheduled at the Nagri of Mahakal Kaleshwar. But anyway, with all the dynamic effort of Pranjal and all the panelists, we are doing this. So welcome panelists on and all the people who are with us on the eve of Republic Day. So what is it is a century of clarity or confusion. Being like it so much, like say I am a very senior obstetrician, but I think today I also be confused many times that what is good and compassionate for this patient or for this couple. So patient childbearing is a physiological thing, or it is a frightening, anxious 9 months. Today everybody takes this 9 months as a disease process. Professional bodies, WHO says it is make it is a positive experience, but are we really able to do that with so many like issues in our system? Obstetrician, always we are so much confused, and we have to take the economic resource of family, patient, as well as the country. And what is the silver line on the cloud, that the Kerala in our own country and Sri Lanka, Kerala in South and many states, and Sri Lanka in South Asia have shown that the low economic and constrained economic resource are not the only way we can optimize obstetrical outcome, we can optimize maternal and health statistics if we optimize knowledge and resources. So coming a very, like just a very light question to Dr. Sudha, a very, very senior obstetrician, that what you say, that what you see the change, like Dr. Deepika Deka says, yes, we should do this thing that is in the context of prevention of birth defect. What you think that today we are having too many drugs, too many doses, asking too many visits, it's a really desirable scenario, or we can have the risk stratification so that we should know that which patient require very close follow-up and which patient require a little, we can have a little lax on their visit and on their other things. So a brief comment as an expert, Dr. Sudha, for your this changing world observation.
Thank you very much, madam. Thank you, ISOPARB and Sadhna madam also. In the current scenario, what we are observing is, I work in a government medical college where the resources and fetal medicine availability is restricted. But the women themselves come with lot of reports, lot of prescriptions, and they also request for weekly ultrasound. So maybe they are either too anxious, or they have been misguided that a scan every visit or every week might help, and it will relieve their anxiety. But it is the other way around. So as earlier days are being our seniors, also our own people, elderly people at home, they wanted us to have some peace of mind when the woman is pregnant. So according to that, I feel too much of knowledge, too much of drugs, too much medication, too much of investigations is not good, because it can cause anxiety in the pregnant women, and it should be restricted only to high risk pregnancy, or where already the risk to the fetus or the mother has already been detected. That is my opinion, ma'am.
Thank you very much, Dr. Sudha. It was the golden word, and what we say, it is the basic of medicine that treats you, heal post and the comfort always. That is the Hippocratic thing. And I think that the Hippocrates and the William Osler and said everything which could be possible for the medicine. Despite having that much of advancement, it remains the principle of medicine. And it is rule of 9. Dr. Gangadhar Sahu have already said Navda Bhakti, Hamara Navdwar Sharir. It is, we have 9 senses, 9 rases, and the human antenatal span is 9 months, and where is our role? So Dr. Deepika has set the stage about preconceptional care, and thought is much before creation, because factor A, life comes from where we actually don't know. So coming to Dr. Bharti, we want to have your opinion.
Yes.
That what you need, that preconception care, like I think 5 or 6 years ago we didn't have. What you feel, where is the need that we should be updated in that, because the people are coming, and when you do the patient come for preconception counseling, or when your patient, you are like advice, what are the crisp things? A lot of things, so actually nothing is done finally. So your crisp message for preconceptional counter, what is the need in today's obstetrical practice, and how beautifully we can optimize the preconception care?
Thank you, madam. The preconception counseling, it is the time where we can identify and assess the high risk factors so that we can reduce the morbidity and mortality of the fetal and maternal morbidity can be reduced. And it is very important because this is the time we can get a, hello?
Yes, yes.
Yeah,
I'm
you
audible.
can hear you.
Yeah. This is the time we can identify the high risk factor, optimize the maternal health, give her education, and pre-conception counseling is important also, because nowadays women are coming with many chronic diseases like chronic hypertension, diabetes, epilepsy, psychiatric illnesses, and it is also important to diagnose the medical, surgical problems and other infections which are causing the fetal and maternal
Please,
this thing.
see that mute everybody except panelists and ourselves. Please, yes. Yes.
Okay.
Yes.
Yeah. So we can identify the many infection during this period, and it is the I think it is the tool to diagnose and early diagnosis of diseases. We can give education to the mother and avoid the complications. I think pre-conception counseling should be in the routine medical this thing, and it is important to avoid the maternal and fetal complications.
So thank you very much. So there is a need, because these are the intervention which can actually, we can, first of all, we can diagnose the things, like you say, reproductive tract infection, endocrinological disorder, genetic issue, and then we can like have the lifestyle intervention or the medicinal intervention, so that you have got the patient enter the pregnancy at the right time. So need and necessity is also there. It is a simple thing that the people are coming, like IT people, very highly professional people, they are coming to us that we want to conceive and what we should do, and we should be equipped with knowledge. Bharti, your one thing, what we'll say a little bit about drugs, because that becomes very, very
exactly.
So what you advise to our people that how we should review the drug and which drug are absolutely known, and we should be very careful about few drugs actually which we want to
actually review. Drug history is a very important. We should review on the drug, like the anticonvulsant. See if the patient is on the anticonvulsant drugs or anticoagulant drugs, or if he is taking any radioactive drug, because these are the effect on the fetus, and they should be stopped and planned during the pregnancy.
So this is very, very important, because if some patient is taking, especially what we say anti-hypertensive, few anti-hypertensive, few anti-epileptic, and especially if the patient on anti-tubercular or anti-leprosy, that preferably they should be finished before conception, and few about anticoagulant like warfarin drug, that once you become pregnant, then you have to switch over. So that is the prior knowledge, that once you become, many drugs are not to be stopped, but they have to be notified that once you become pregnant, you should like switch over, you have to switch over to the other drugs. So these are few drugs, and we will not go into details of many things because every question is a like a subject of a full CME, one day CME. So we will have that there is a like need for the preconception care, and this should be the part of our regular obstetrical practice. One comment from about the nutrition and the folic acid, and Pranjal, you take away. You take over to the Ritu for about the folic acid, because it is one thing what Dr. Deepika said, the frightening thing. Still, we don't have much to give to our patient except a good nutrition and folic acid around conception period. We don't have anything more intervention we have found. So Pranjal, you take over for the next
Yeah. Dr. Ritu, as we all know that there is a much role of the preconceptional nutrition as well, especially in this era. So we would like to brief you about this thing.
Thank you very much. Actually, preconceptional also, folic acid is being advised to the patients to take because of the neural tube defects, which is quite prevalent. So these things are to be given. And in this, there are two categories of drugs like L-methylfolate and folic acid. First of all, I would like to differentiate between the folic acid and the L-methylfolate, which is a better one. Like L-methylfolate is actually, it's primarily a biologically active form of folate. And this acts at the cellular level for the DNA replication. Whereas folic acid is the vitamin B9, and it is a part of the B complex, and it is found in green leafy vegetables. And this vitamin converts into folate in the body. So thirdly, methylfolate is methylated, and this is unmethylated. Then folic acid is important for, can cause deficiency, can cause anemia, whereas L-methylfolate deficiencies can lead to L-methylfolate is applicable for DNA replication, cysteine cycle, and for regulation of homocysteine. There is also a difference that in L-methylfolate, since it is biologically active form of folate, therefore this is quite readily absorbed, and this does not lead to any kind of accumulation. Then there is a condition like MTHFR. 40 to 50% of patients might suffer from deficiency or decreased level of enzymes. So in the places where fortification has not been done of the food articles with folic acid, L-methylfolate should be recommended because folic acid has low absorption, and in MTHFR deficiency, it can lead to accumulation in the blood, the unmetabolized part, which may cause so many health issues. So it is advisable to give L-methylfolate, and this is bioavailable also, it is well absorbed also, and it has no upper limit intake. So I think folate should be given as a preconception as well as should be given in the first trimester. And if the patient is on anti-epileptic or something, then it should be continued to the whole of the pregnancy.
So Ritu, I believe it is folate for both husband and wife, a couple. Both of them should be treated with the folic or L-methylfolate, which is a new this thing with promising results. Ritu, any small take on vitamin D prior to conception? Nowadays, like age at 30, they are considering.
There are combinations coming along with the vitamin D3. So I think this is advisable, and because things are increasing and in advance, so this vitamin D3 should also be combined with folate and to be given to the patients.
Thank you very much.
Ritu. I think you have taken, Pranjal and Ritu, taken very, very valid that the folic acid is the only intervention which as a obstetrician and as a science we have known that it reduces many, many birth defects. Folic acid conventionally we have been given from a long time very rightly, and now with the evolving science we are having the new generation, and there is always a cost issue. I cannot always like we have to consider. So takeaway for today's obstetrics is that folic acid for all, but methylfolate, the patient who can afford and the patient who have the bad obstetrical history, because by any means we cannot detect the FDHFR polyporphism and we don't know that which folic acid is really going to be active or not. And every patient with the bad obstetrical history, I think this is the time to switch for the better alternative, that is L-methylfolate. And what Pranjal was saying, it is a hidden hunger, that is multiple micronutrient deficiency. And the folic acid with the multivitamin is the key to like reduce not only the birth defect and other thing, is also to like have a good outcome after iron therapy of anemia. So this is one message, and thank you very much for all the input. So coming to, I think we have done a little bit too already. Dr. Sudha has taken a risk stratification. Dr. Deepika Deka has said very much, and we have given a lot of discussion on changing pyramid of antenatal care. So, but the issue in the ground reality is that how many people can have that 60-minute ultrasound scan for this, and how we should stratify. So Manjula Rao and Dr. Usha, your comment that how far we should utilize the technology and science for this thing, like for some high risk, or and it can help in our system, or it can like making complex our system. So Manjula and Dr. Usha Rai, Dr. Manjula and Dr. Usha Rai.
First of all, thank you, Dr. Sadhana Gupta, madam, and Dr. Pranjal. It's wonderful to be here, invited here. Thank you so much for this question. So as an obstetrician, I think our job sitting in the antenatal clinic is to screen for risk, both the maternal risk and the fetal risk, first based on the history, and then we go around checking her physically. So because any adverse factor which she has, it can impact her well-being as well as the baby's well-being. So as an obstetrician, I think at booking we have to screen her. We have to screen her whenever she comes for checkups, and then intrapartum also we need to screen. So at any stage, a low risk mother also can become a high risk. So, and also the fetus. So our whole antenatal checkup or screening, what we do is basically to detect any risk to the mother and the baby. And risk stratification also is important at the time of booking, to see if she has any adverse condition in her medical history or in her physical checkup, her nutritional status, her body mass index, whichever is going to affect her pregnancy. So stratifying her into high risk, low risk also is extremely important, I think. And this screening has to be done for all antenatal mothers. I don't think and it is then we segregate at booking. But we should not forget that throughout pregnancy, a low risk mother can become high risk if she develops hypertension or gestational diabetes. So I think we should keep that in mind, is my take.
Thank you very much. I think you have taken very, very valid point that the risk stratification is a continuous thing. And one thing really worries me, and it is like an open discussion, that yes, we can have even 11 to 14 or color Doppler and everything. Despite being low risk, you have to follow the patient with all blood pressure monitoring, with all the anemia, which so many things we have. So we cannot be lax even if the risk stratification is low. It is an ongoing thing, and this is very important that we always like continue to have the risk assessment throughout the period. So few template, which is a high risk mother with a high risk infant, high risk mother with a low risk infant, and that template we should keep in our mind, like high risk mother with a low risk infant, maternal asthma, venous thromboembolism, but the fetus is fine. Low risk mother with high risk infant, patient is normal, but fetus is having IUGR or something like a birth defect, and a low risk mother with low risk fetus. So why Western world has thought of it? Because in their scenario, these are the midwives are taking the care of low risk. You cannot like consult a specialist if you are you are having low risk and no issue. In our setup, we have to like optimize our resource, because the patient can see really obstetrician, and this risk stratification can really make us up our mind that this patient needs 12 or 16 visit, or this patient need only 7 to 8 visit. So we have the knowledge, but we have to optimize according to our scenario, And this is very again important that we have all busy OPDs, crammed OPDs, and a few sections are having a lot of investigation like iron. What I'm saying, 12 gram hemoglobin, but TIBC, serum iron, what not is being given. And that is the thing that we should, like as a clinician, we should not be very like encouraging thing, and we have to be very, very clinical oriented. What is the patient's clinical perspective? So coming to, we have to set our goals and respond to current challenges. Any panelists want to add to this point of a very clinical risk stratification? Any panelists want to add that before we go to the next question? Any panelists want to add something?
Ma'am, I would like to add here. I would like to add something here.
Yes.
Screening should not start only after conception. It should start from the adolescence only, because there are certain risk factors which present during the adolescence, and these are the women who enter motherhood. So a general awareness program should be conducted for a healthy living and health of an adolescent who is and just before she enters motherhood. I feel that is very important. Healthy living and ensuring the normal healthy status, and then precautionary measures, and how to take care, what are the preconception care which she should take. All these have to be educated as a part of health awareness programs. And even during pregnancy, the general public has to be aware of what problems and what is the need for screening protocols, what is the need to come to the hospitals, and where to go and what exactly to do. So it should be a part of our public health programs, ma'am.
So thank you very much for it. Adolescent health intervention, and I think the girls are different, so the reproductive sort of what vaccination. And I think one, I'm not able to see the panelists because the speaker view. So before we go to the Pranjal, you go to the other question, and if Preeti is not there, then Ritu or anybody can take.
Ma'am, I want to add something, ma'am.
Yes, sure, Vaishali.
Ma'am, actually, regarding, as madam has pointed out that regarding adolescent girls, so there's a need for, ma'am, rubella vaccination for all adolescents. And ma'am, in the preconception period, we should check for rubella IgG antibody to know whether they are immune to rubella or not. And if they are not, then we should vaccinate them, ma'am.
So your takeaway is the rubella vaccination in preconception counseling, we can say, and the preconceptional counseling, what madam has said, actually it is a preconcept. Adolescent health intervention are the preconceptional counseling. And a little bit about that, the male should also be involved. Male PCOS, we have a beautiful concept, male PCOS, what smoking, substance addiction, many things. So the male is also part of this. So Pranjal, you go for the next like question, and if the Preeti is not available, then Ritu or Manjula, anybody can take it. Pranjal, please.
Ma'am, you are not audible.
Pranjal, I am not audible.
Oh,
you are audible, Dr.
I highly appreciate the words of Dr. Sudha and Dr. Vaishali. Actually, indeed, Foxy is doing the great job through its adolescent committee. We are vaccinating, we are taking the rubella camps time to time. Every society is taking. So that thing is a long way to go, but yes. So next question is again screening. I think Dr. Manjula, anyone can take this question. Dr. Manjula, while screening, see, a stitch in time saves 9. So while screening, we go by the clinical methods, we go by the battery of investigation. So what is your take for this, especially universal screening versus selective screening?
I think some things we have to screen universally, whether it is screening for anemia or screening for diabetes or thyroid. These are accepted, and even our Foxy guideline on antenatal screening suggests all of these. Apart from that, in fact, even screening for thalassemias also is recommended, and we actually do it in our hospital, routine screening for all antenatal mothers. So definitely screening. Anemia is so rampant, we have to check for her nutritional status. Screening for hemoglobinopathies is recommended, but again, there are resource constraints. So it is recommended, but I think it depends on which resource area you are in, the type of screening. Of course, screening for blood group, and these are all very routine and they have to be done, without which I think the assessment of a pregnant mother is never complete. And screening for infections, yes, is primary to prevent mother-to-child transmission of hepatitis B, HIV, and syphilis. I mentioned diabetes, thyroid disorders, and urine culture also to prevent, to detect asymptomatic bacteriuria and prevent ascending pyelonephritis in mothers. And see, aneuploidy screening, structural anomaly screening, I think is extremely important. But again, I can understand in a public hospital, doing an NT scan, aneuploidy screening may not be the priority. So in such a place, TIFA scanning at 20 weeks is definitely a very important scan. But ideally, I think we have to go by the pyramid, which says that in first trimester, you do screen for anomalies, and that is the aneuploidy screen, the NT scan, and also now wherever resources permit, the preeclampsia screening, because that also has the potential to save mothers from severe preeclampsia. So ultimately, I think we have to select the most important ones, and ideal situation, you have to go by all these screenings. But sometimes I can understand resource constraints where you prioritize which one you select.
Yeah, I would also like to add that normal investigations like blood, urine for thyroid and everything should be done in every patient. But as far as neonatal screening is done, we should take elaborate history. If patient is definitely at risk, if she's having any past pregnancy, she had certain problems in the baby, or any kind of in family history also, then she should be allowed for all this, because it is no fun in scaring a patient about it, because the patient might come out to be positive, and then the whole lot of things, they are misinformed also, and sometimes they might not turn up to a doctor, they might decide among themselves only. So I feel that aneuploidy screen should be very, very specific to the patients who have a family history, who have positive history. And since Gorakpur, where I'm practicing, people are okay economically, they are not very sound. So we have to be really judicious in prescribing any kind of investigation. And aneuploidy screen, because here certain centers, many of the centers don't have, few of the centers have this facility. They might need to go to Lucknow or any other place. So I feel that elaborate history on the part of the doctor, and doctors have to be very judicious while going for this. And aneuploidy screen is nevertheless very important.
Thank you, Ritu. I think Ritu and Manjula has said, so few things are a must, and I will really like to give this message that we must screen aneuploidy in some way. Always for universally also, because what is the thing that we had the aneuploidy or the birth defect in high risk patient, but we can have in any patient. So whenever the patient comes to us, we should be a little careful about it. Like you can learn anti-scan, it is not very difficult. A good ultrasound, a little visualization can make you really doubtful, even if the patient is coming at 60 to 18 weeks. And because one message I think we will like to give, that the birth defect as well as the aneuploidies are common in every age group, especially in economically disempowered. The nutritional deficiency are also cause of it. So it is always better to think about the neonatal screening universally for all the patients, whatever way is the most suitable, and whatever our circumstances, when the patient is coming late or early or whatnot. So it is all that few things are really they are required, and this is not moving.
Yes. Yeah, I do agree with you, ma'am. Universal screening is needed, but whatever available resources, with that we should do. And whatever is the region-wise, whatever is the major health problem, according to that, screening can be conducted.
Yes. So like if the patient is having past history of Down or something in the family, then we should go for the diagnostic test more early. And if the patient is having low, then we can go for the screening procedure. So we have done a lot of screening tests, and it is positive. And when it is positive, what happens? So we will go very, very quickly. We will come, time allotted is till 7 p.m. So we have 30 minutes left. So hepatitis B, because this is something important. Yes, we do. And suddenly, negative we read, and suddenly we read it is either hepatitis B, husband is positive or the woman is positive. So Dr. Manisha and Dr. Shobha, why this hepatitis B? Because every screening procedure has come with a vigorous thought process. So when it has become positive, a quick message to all clinicians, what should be 1, 2, 3 points that what should be done. Dr.
Yes.
Manisha and Dr.
Yes.
Shobha, please.
Yes, ma'am. The screening of patient for HBsAg hepatitis B is done during first antenatal visit of the patient. As we see, it is been recommended. And if the patient comes positive, then the counseling of the patient about the risk of transmission from the mother to fetus is to be properly done. And the visits of the patient has to be planned, and this patient should be considered as high-risk patients. Now, again, the testing of hepatitis B DNA levels should be done, because if they are found high, then there is always a high risk transmitting infection to the newborn. And it also can cause acute hepatitis, and we can have serious sequelae like cirrhosis or hepatocellular carcinoma. And LFT should be done in this patient. Then again, I will add that timely hepatitis B immunization of the babies, both active and passive, that is shortly after the birth, immunoglobulins and 3 doses of hepatitis B recombinant vaccine, it should be given to the infants. Otherwise, they may become the chronic carriers. This is my for this.
Thank you very much, Manisha. Dr. Shobha, you want to add something about? Especially if the either discordant hepatitis B positivity, any clue about vaccination and safe sexual practices, Dr. Shobha? Dr. Shobha?
Dr. Sudha.
Dr. Sudha. Yes, Sudha. Yes, thank you. Sorry for mistype, Dr. Sudha. Yes.
Sorry, madam, I couldn't make out because there was
your name is
problem.
Your name
there was
is
some electrical problem. Can you repeat the question, ma'am?
If hepatitis B discordant positive, either husband or wife, one is positive, one is negative, then what is the role? And the role of antiviral agent, like say na time to send to fetal medicine specialist and time to send to physician. If the hepatitis B positive on screening on any partner, this is Dr.
Yeah, there is definitely a role because the baby might be born. There is a born with hepatitis, congenital hepatitis. Healthcare worker is also at risk. So I would like to get a evaluation done. It need not be hepatitis B also. It can be other variants also. So I would like to refer her to a physician, and it's his choice to start the antiviral. And we should take all the precautions that during delivery, all the universal precautions are taken, and the baby has to be protected with immunoglobulin at birth. And post birth, the husband, if he was negative, he needs to be protected against hepatitis B by vaccination. And later, even they have to be advised regarding barrier contraception and future conceptions, the care before future conceptions. All these has to be advised postnatally.
So thank you very much. If the hepatitis B discordant, then the vaccination of other partner, that is important. Better that all family members are being screened for the hepatitis B. This is very important. And when there is a high viral load and hepatitis B antigen, we can say as a surrogacy for the viral load. And if it is positive or it is high viral load, then the use of tenofovir, that is very, very important from 28 to 32 weeks. So this is very important because sometimes we send the patient to physician, but they don't have the time. So that much of knowledge we must have if it is a high viral load or if it's HBe antigen positive for protection of healthcare for the mother to child transmission. The tenofovir is the drug of choice, which is to be done from 28 to 32 weeks. Always be ready with the child immunization, because sometimes for the passive immunoglobulin you have to like say 2 hours to order sometime, that it is not sometimes freely available. So every person should be noted, every person in the family, wherever the delivery happens, you have to give the active and passive immunization for the children for the newborn hepatitis B, because this is the failure of vaccination in the neonatal period is the one of the very important cause for the hepatitis B having all over the world. So this is very important. Syphilis and hepatitis C, Bharti, Dr. Bharti, what you say,
Yes.
we should do or we should not do?
No, we should do the syphilis, all the pregnant patient, because it causes the, during pregnancy, it may cause the abortion, stillbirths, and in the fetus, it can cause congenital syphilis disorder.
Actually,
So it
people
is.
says that the syphilis has gone. And
Yeah,
still
but then also.
so what's your takeaway about it? Yes.
No, we should do it.
Yes. Because it is on the rise actually. What
Yeah.
I'm saying that it is on the rise, and it is around 9,30,000 maternal syphilis infection, and so many, it is 3,50,000 adverse pregnancy outcomes. So the many people, we cannot go like without having the screen for the VDRL. And what your takeaway, you do hepatitis C screen for all or for some risk factor, whatever?
No, we are.
Only risk.
Actually, we are not doing for the all ANC patient, but only at patient they are high risk. For that, we are doing vitamin C screening tests.
So Dr. Sudha is also of you only in high risk. So even no professional body says that hepatitis C should be screened universally, but the like American Infectious Disease Association say that it should be done in the antenatal period, and in the high risk like affected partner, other people with STD, drug usage, and this is other thing. Dr. Pranjal, next question. RH negative, I think Dr. Deepika has taken a little bit. I think we want to have the Pranjal, you take RH negative
Yes.
about what to do. Yes.
A positive RH positive in case of RH positive husband certainly becomes negative in case of RH negative woman. So Dr. Ritu, what when the mother is negative, what is your plan of just in first ANC visit if she is found to be negative? So just shortly enumerate your plan of treatment or plan of progressing ahead in that case.
When I get a patient RH negative, then immediately we get the RH positive, investigation done of the husband. And if the husband turns to be RH positive, then we put her in a high risk case, and then we proceed accordingly, like indirect womb test. We can we get it done. Indirect womb test, ICT, at 18 weeks of pregnancy, and then 28 weeks, and so on. Ultrasound also should be done. And then ultrasound, first of all, I'll go with that in the first trimester, ultrasound is done. And then in the second trimester, at 20 weeks, we should do the level 2 scan and keep on with it. And sometimes in 28 weeks, if the patient is when 28 weeks, then should be given ROGAM, that is anti-D, should be given. And then after the delivery also, the patient is to be given. And in case the patient has had some kind of trauma or anything, then also we should recommend the patient for anti-D injections.
So Vaishali, you will like to add something? And Pranjal.
Yes, ma'am. I would like to add one thing, that along with all these things, one more thing I am counseling the patient, that RH negative patient should not become anemic. That is very important, because ma'am, I am in medical college, and ma'am, we are just dying for blood all the time.
Yes.
So I think that as soon as we find that the patient is RH negative, we should counsel them, and as well as their family members, that you please take care that she should not become anemic, because it's very difficult to arrange blood. And ma'am, one more thing, that because of feto-maternal hemorrhage, this RH isoimmunization occurs. And ma'am, during delivery, mostly feto-maternal hemorrhage occurs, but only 10 to 15% patient become immunized, and not all the people. It's because of it depends upon the inoculum of blood that is transmitted to the mother. And ma'am, some are RH non-responders. It is a genetically determined thing. And ma'am, by giving postpartum prophylaxis, we can reduce the incidence of RH isoimmunization to 1.5 to 2%. And if we give antenatal prophylaxis also, then ma'am, it is reduced to 0.18%. So there's a need for antenatal prophylaxis also.
28 to 32 weeks antenatal, yes. Take care of the anemia of both mother and fetus.
Yes, ma'am.
Yes, and ask the relatives to keep the blood ready at any time of point. RH negative we rarely get, so these are the takes for RH negative mother. She should be specially categorized. Specific note should be put by red marker pen on her card that she's RH negative. So all of us must be doing this, just to enumerate. RH immunization is one condition which usually have good prognosis if managed properly. So for management, for properly managing, we have all these webinars and these discussions. Screening and prevention protocols should be effectively applied. Good lab test, right interpretation. Even nowadays, color Doppler to see the MCA can give you the idea of the fetal anemias. Make a mutual respectful team and spectrum from OBGYN, fetal medicine centers and expert. And like Deka madam said, that 7-9 Cloud Hospital, they're like huge work. I was astonished to see their huge work in fetal transfusions to take care of the
that was AIMS data. That was AIMS data.
That was AIMS data, but like really at some smaller setups, we really do not know this. So that was a really good takeaway that we can timely refer these patients, especially recurrent hydrops if we are coming across.
At the same time, I want to give one very important clinical message to all. When you are prescribing medical abortion drug to anybody, married, unmarried, whatever,
blood group,
get blood group RH typing. What Dr. Deepika Deka is having like a good number of RH isoimmunization. The rampant use of medical abortion drug is one of the cause. And even if the patient is primary gravida, you always get the ICT done. Don't say that like primary gravida and it is not so. So we have to do, because we never know that she has been done like any pregnancy or something. So medical abortion is thing that always we have to be very, very careful. So endocrinological disorder, I think we have fed the question, Dr. Sudha and Dr. Usha, to you. It is diabetes and endocrine disorder. So my question is that it is universal or selective first, and secondly, that for the GDM, what tests you are doing in your setting? So Dr. Sudha and Dr. Usha. Dr. Sudha and Dr. Usha, yes. Dr. Sudha, Pranjal, just say.
Dr. Sudha, madam, are you muted?
And Dr. Usha can take. See in the screen.
I request someone to take this question.
Anybody, yes.
I think
yes.
Screening for diabetes is universal. There is no doubt about it. Either we follow the DIPSI method, wherein the woman comes in with, she doesn't have to fast, and she takes 75 grams glucose load, and after 2 hours you do the glucose test, and that is both diagnostic as well as screening is what is recommended in India, the DIPSI method. You screen at booking, and again screen if she's very high risk between 24 to 28 weeks. That is what is recommended for screening. It is universal screening. There is no two ways about it.
So you want to have this is the thing that is 75 gram glucose, that is DIPSI test. So what you recommend, it is a, like some people say we will do postprandial, sometime because of the patient doesn't want to wait. So like people switch to the random. So why the DIPSI test or the glucose challenge test is so very important, and we cannot rely on the only postprandial or sometime random. So what is important, please communicate to all people about it.
See, the DIPSI method was recommended keeping in view the problems in public hospitals where women come in from far off places and they cannot undergo a formal glucose tolerance test where they have to be fasting, take some glucose solution 1 or 2 hours and all, which is the IAD PSD one. But for our country, DIPSI is recommended because these women can be screened irrespective of their fasting status, and it has been validated by research that you do 75 grams of glucose load you give, and 2 hours later, if you measure the sugar, plasma sugar levels, even simple glucometers also, it doesn't have to be a lab kind of testing of the sugar. So that if it is more than 140, you think that she is gestational diabetes and you treat her accordingly. And there is no need to do a fasting plasma glucose levels in the DIPSI method. That is what is recommended for our country.
So thank you very much, because it is our problem. The Western world don't have that much of GDM also. And secondly, what is we want to give that the patient need a glucose challenge so that the hidden GDM, hidden glucose intolerance gets covered up, like it becomes revealed. So the glucose challenge is very, very important, and we need the total universal testing for the GDM. Maybe whatever method it is, but the DIPSI method, which is like COVID, we have done like DIPSI method is followed, and that it has been appreciated by many people. So Dr. Sudha, are you there? Dr. Sudha, we want to have that if we have the high glucose level in the first trimester, why it is so much important to know, because the early first trimester detection may be the already having the patient diabetes, and that is causing increased risk of congenital malformation, complication, need for prompt treatment, and ensure prompt treatment after the diabetes. So the GDM has got a little better prognosis, but the early, like the patient having pregnancy, diabetes before pregnancy has got the more implication either to the mother, to the fetus. So we like,
I'm
yes,
there. I'm
yes,
there.
yes,
But
Dr.
my camera was not working. So it could be, the concept is universal screening of all the pregnant women. The moment they enter pregnancy, soon after they cross 16 weeks, with a simple, economical, feasible oral glucose challenge test as per DIPSI guidelines and WHO guidelines, with 75 grams of oral sugar intake, irrespective whether they have postprandial or pre-meal or post-meal. So this can detect more than 75% of gestational diabetes mellitus. And detection is very important because if you screen them before 16 weeks, we can detect overt diabetes when there is adverse event both in the mother and the baby, and an additional risk of fetal congenital malformations. If it is gestational diabetes detected after 16 weeks, then there can be effect on the fetus and the mother. The fetal affection is more because there is more chance of, if there is hyperglycemic episodes, there is more chance of fetal hyperglycemia leading to macrosomia, delayed, there is prolonged labor and injuries both to the mother and the baby during birth, and increased incidence of neonatal ICU admissions, septicemia, metabolic problems, then hypoglycemia in the newborn, electrolyte imbalances. And not only it doesn't end there, the baby born to the mother who had gestational diabetes, the mother can develop after 10 to 15 years or a little earlier based on the maternal age. She's also prone for diabetes mellitus development later. And the baby can have obesity. It is prone to have obesity and early onset of diabetes if it is born to a diabetic mother. So to prevent all this, universal screening is very important so that the disease is controlled, ma'am.
So it is fetal origin of adult disease and the long
As per Barker's hypothesis.
So well. So Dr. Usha, we are doing thyroid screening. I think we will have a 1 or 2 panel poll that what you do for screen T3, T4, TSH, free T4, TSH, or with full antibody titer for screening. So Dr. Usha, your what you do and what the panelists, 1 or 2 panelists do, only TSH or the full profile or the free T4, which is a little costly one also. Yes. Dr. Usha?
Usha madam has
she is left. Dr. Sudha, you can take over because we could not hear you. Dr. Sudha, what's your takeaway of the full screen or the less screen, only TSH screen?
Dr. Manjula, if you can take this question.
Yeah, so ma'am, in routine practice, routine screening is only TSH. Only if it is abnormal, then I will, do a formal testing or do anti-thyroid antibodies. But routinely, I will just do a TSH practically. But I think what is recommended is TSH and free T4 measurements.
So any difference of opinion from the other panel? So rightly, I'm also doing TSH only for a screen. So any difference of opinion from other panel?
If the TSH level is between 2.5 to 3 to 10, then we need to do free T4 also. And if free T4 is low, then we need to do anti-TPO antibody titer. Then decide whether we need to give levothyroxine or not.
So thank you very much, because it should be the directed, but the first screen method can be TSH. I think all panelists will agree to it, and we will do accordingly. If what is the reading, it is 2.5 in the first trimester and around 3 to the second trimester. So Manisha, Pranjal, your
as we all know that anemia is one of the biggest reason for increasing maternal mortality, maternal morbidity, as well as perinatal mortality, morbidity. So Dr. Manisha, what is your routine practice to screen for anemia? It is very interesting and it is ever growing. Like day by day, we are getting so many new inputs for that, for this simple thing. But as Foxy has decided to go towards the path of the Anemia Mukt Bharat, 12 pe 12 is going on. So Manisha, your take on that screen of anemia?
Yes, madam, we all know that it is the most common medical disorder in pregnancy, and in India it is more prevalent, and more often nutritional, that is iron deficiency, is most common in our country, and it also contributes to maternal and perinatal morbidity and mortality directly or indirectly. And we all know about the classification mild to severe type, that I am not going into detail, but then we have to see what are the recommendation. Actually, universal screening of IDA with hemoglobin is done in first visit. CBC is preferred wherever possible. Mostly low resource setting, we do it in the first visit, and we start with elemental iron during her first visit, maybe patient mild to moderate, and further investigations are done if patient doesn't respond to the iron therapy. That is CBC HB is repeated, then peripheral smear is to be done, RBC indices are to be done, reti count, then PS for MPA where the malaria is more endemic, stool examination for ova, cyst, parasite, and occult blood. When there is chronic blood loss, we are suspecting. And if we are getting a persistent microcytic picture, then preferably if HPLC is available, we do it to rule out the hemoglobinopathies. And serum ferritin can also help to differentiate from IDA and thalassemia treating most of the things. But we have to remember that most of the time, all blood samples with MCV less than 80 and MCH should be investigated with HPLC and HB electrophoresis. That is the most take-home messages. And we have to think that MCH, it is most reliable indicator, and borderline if the HbA2 level are below 4, it must interpret with caution, and confirmation by DNA method for the diagnosis of thalassemia is to be done. Genetic counseling is more important if the patient is suffering from any hemoglobinopathies, and accordingly, according to the results, we give the treatment to the patient.
So minimum 3 times CBC in her full pregnancy, minimum 3 times CBC, and minimum 3 times. And if the patient is found to be less than or near around 9, then strong suggestion for serum iron. If serum iron or serum ferritin is less than 15, then one must go for the HB electrophoresis of the battery of investigation to rule out the hemoglobinopathies.
So one thing before we switch to the other question, two things like aneuploidy, we must be very careful that hemoglobinopathy is very, very common in our country, especially in few ethnic races, and now with the so many migration and interconnectivity, we can have anywhere. But read ABC or CBC very well. If you find that it is the microcytic hypochromic anemia, MCV less than 80 and MCH less than 27, consider that patient can have the thalassemia, and whenever you think that the HPLC or hemoglobin electrophoresis should be done to confirm it. So it is not necessary that every woman should have the HPLC, but it is necessary that we think of hemoglobinopathy in every patient and read out the all details of the total blood count. Don't go for only hemoglobin. Don't omit this chart which the people are doing with analyzer. And with this, we can do very cost-effective thalassemia hemoglobinopathy screening as well as a good treatment of anemia. Because you read out the good CBC, then you know it is a megaloblastic or it is a dimorphic anemia, what type of anemia, and we can supplement it with right folic acid, vitamin B12, vitamin D, what is causing this anemia, and we can give the good treatment. So I want to say, like aneuploidy, always think that the patient can have hemoglobinopathy, but you have to look to the ABC of the CBC. HIV, I think we will be having 10 minutes more. So HIV, one comment from Dr. Vaishali and Dr. Bharti, that when if it is positive, what to do? A little quick, very quick remark. And it is
HIV, when HIV is positive, we should refer to the patient or take the opinion of the physician or refer to the ART clinic. And this ART treatment she should take throughout the life, so the child transfusion is reduced.
So thank you very much. Don't throw away the patient. What I want to say, don't throw away the patient. Oh, HIV and whole like shush in the full hospital.
Madam, nowadays the corona has decreased the importance of HIV very much.
True, I know.
And every pregnant patient with HIV positive must have the antiretroviral therapy. There is no way, and like refer to the right people. Government is doing a lot of things, and there are many centers about it. Where we will be very quick now. The rapid fire round is there. For hyperemesis, nausea, vomiting, Ritu and Preeti, if you are there, what you are the clinical tips? A very common thing, but nowadays people are very upset with this. So Ritu and Preeti, how do you deal with nausea, vomiting, and a little bit about hyperemesis? It is a rapid fire round, and we will sum up in 10 minutes, I think.
Yes, ma'am. Nausea, vomiting is very common, and it is known as morning sickness, which is found in 80% of the patients, and patients are very uncomfortable with this. So in this, first of all, what I do is change in the lifestyle of the patient is very important. Patient should be told that to take 5 to 6 meals, that is small and frequent diet should be given. Not necessarily that 3 major meals should be given, because she might feel not very comfortable with it. And she should avoid any kind of greasy or spicy food. And then she should take plenty of water, at least 8 to 10 glasses of water, and in between some splash of lime or fruit juices can be taken. Then after brushing her teeth, immediately she should take some toast or some less oily thing like biscuits, etc.
Anything about drugs, this is their lifestyle, yes. And any drug which you say that it is,
yes, ma'am. Commonly we prescribe the combination of pyridoxine and doxylamine, and if the patient is not relieved, then antihistaminics can be given. Dopamine antagonists like metoclopramide and promethazine can be given. Then even serotonin antagonists like ondansetron can be given. Sometimes patient may resort to acupressure and acupunctures also. And hyperemesis gravidorum, then
yes. No, I was saying that actually. So it is the good dietary counsel, and what I want to say that please take every drug with a caution, because the thalidomide tragedy is hanging over the future. So aneuploidy, I think Pranjal, can we leave it because it has been covered.
We had a Yes, we had a discussion.
And we should have a like a first trimester and the second. So coming to second trimester, Dr. Sudha, are you there? We are really missing.
I am there.
So Dr. Sudha, when second trimester, the nausea, vomiting has come, and now in second trimester, it is time to relax, or it is time to be a little cautious. What do you expect in second trimester, Dr.
Yeah, in the second trimester, it is time for the mother to relax and time for the consultant to gear up to screen the fetus and also the screen the risk factors in the mother. So it is a right time to screen for gestational diabetes mellitus. Even for pre-eclampsia, early detection can be done, and to screen other risk factors in the mother. So it's high time during the antenatal period, there should be a good screening, good counseling, good advice, dietary advice regarding the need for adequate rest and need for repeated scans, when to get it done, and then if detected, what is the next and when should she come for the next visit. All these advice have to be given. So the doctor has to be awake in the second trimester and the patient should rest in second trimester.
So one question, actually, we have a very little time, but we will like to have Dr. Sudha, your opinion. One takeaway is that every scan should be a very good and thorough scan. And we do targeted imaging for certain thing like something risk factor or something, because it takes around 40 to 60 minutes and the cost also. And the patient is sometimes frightened. And we had a very good panel just now, soft marker, that patients are not aware that they can have this possibility, and now because of it you should go to the diagnostic test. So every scan should be a good and thorough scan, and the targeted imaging for a risk woman or a risk fetus, or it should be always universal. So what's your takeaway, Dr. Sudha and Dr. Bharti, in Indian scenario? Because
in the second trimester, it should be a universal screening of the fetus. If there are no soft chromosomal markers or any other abnormalities detected, then we can reassure the patient. And then if all the other screening, what we told, are all normal, then we consider it as a low risk pregnancy. And then it should be a routine clinical examination with a growth assessment scan once in third trimester. But TIFA scan has to be targeted if there are detected risk factors in early pregnancy, or if the pregnancy is branded as a high risk pregnancy, then a TIFA is needed. And all pregnant women routinely, universally should have one good TIFA scan in second trimester, so that there can be early detection of any chromosomal anomaly or a structural anomaly, so that there is time for selective termination also, which should be done within 20 weeks of gestation.
So thank you. 16 to 20 week anomaly scan is the most important, irrespective of aneuploidy or irrespective of what is the first trimester screen. Even if it is totally negative, every person need a very good scan, and it is a matter of learning actually. And I think that what is my dream, that every obstetrician has a good sonologist, and so that they can do reasonably well for their patient. And whenever there is need, what Dr. Deepika said, then we take the patient to the refer to the fetal medicine specialist, because fetal medicine specialist, if they are doing the anomaly scan for everybody, then they will be also like overburdened. So every obstetrician should be a reasonably good ultrasonologist. So we have to be aware. I think hemoglobin already Pranjal has taken. It should be stick to rule, first visit once in every trimester and then before term. So this is important, and this is the GCPR on anemia and preconceptional care, where I was the part of all the things in 2016 when Dr. Alka Kraplani was president of the FOXI. Dr. Manjula and Dr. Manisha, hypertensive disorder. One thing that 11-14 week we can do Doppler and say risk assessment. A good takeaway, how to take blood pressure in antenatal period, and at what time you start antihypertensive. Very brief key point. Dr. Manjula and Dr. Manisha, how to take blood pressure in antenatal patient.
Antenatal patient mothers, they have to be taken in the sitting position, and one of the arms has to rest on the table, and appropriate cuff has to be selected. because if she's very obese, then the blood pressure measurement will be not appropriate. So these are all extremely important. And she should not be wearing any clothing. A lot of women come with multiple layers of clothes. So those also should be removed, and bare skin, that is where you try the BP cuff. And as far as risk assessment for preeclampsia, yes, I think we should in India go by the gestosis scoring. Although
Yeah, great. Yes. Great. I'm very happy you told about gestosis scoring. So please add on.
Yeah, there is a Foxy gestosis scoring. I think it's a mixture of history on the mother and some of the biophysical characteristics, which gives a score. And based on that, you can start her on ecosprin. Yeah, high resource settings will have the very sophisticated preeclampsia screening using the biomarkers, which is extremely good in predicting severe early onset preeclampsia. So wherever possible, that can be used, but it is not practical to use that in every place in our country. So I think for us, we should just go by the gestosis scoring. And
so one thing very important, because we are coming to one or two things which are life threatening and causing a lot of maternal and perinatal morbidity and mortality. One thing is that the 160, 110 is a sign of severe preeclampsia. Start antihypertensive around 140, 90, what you are saying, Foxy gestosis score, and I was also the part of it. And the third very important message which we want to give, that preeclampsia, what ISHHP says rightly, that the preeclampsia is preeclampsia whenever there is a high blood pressure plus any organ involvement. You take it as a preeclampsia and don't be like a very thin line between a mild and the moderate and the severe preeclampsia whenever there is preeclampsia. That is hypertension with any other organ involvement. It may be fetus, it may be hematological, it may be brain, it may be your heart, and it may be liver or kidney. Whenever there is organ involvement, take it as a preeclampsia and do all the precaution and protocol. Don't say because today it is a mild and moderate preeclampsia and tomorrow it can be turned into the severe preeclampsia. So very important 2 points, that around 136 to 86 or 140 to 90, by 90, you should start antihypertensive and set the protocol for very, very close follow-up of that woman, and of course the timely delivery. Preetam, we will taking a few.
Ma'am, can I add about preeclampsia?
Yes.
Ma'am, one sentence on preeclampsia. Can I add, madam?
Yeah. Low-dose aspirin is.
Yes, and also the
current definition.
The patient will end up in HELLP syndrome also.
Yeah, the current definition does not necessitate the need for proteinuria. That is one. It is excluded for diagnosis of preeclampsia. That is one point I would like to make. The second point is, please add echocardiography also in investigation of preeclampsia, because we have done a study of more than 500 women of severe preeclampsia. We have detected many cardiac problems which also were seen. They also added to the complications of preeclampsia.
Cardiomyopathy.
So please add a good echocardiography also as one of the investigations in evaluating preeclampsia condition. Thank you.
Dr. Sudha, in the same context, I want to say a beautiful paper, placenta is a villain or victim. And now the new pathogenesis is, it is the maternal cardiac dysfunction which is actually causing the preeclampsia and the placental malperfusion. So very rightly you say, the world is round, so you say fetal echo is there, and we are thinking now that it is the maternal cardiac dysfunction actually which is causing the sequelae of preeclampsia. So very rightly the maternal cardiac evaluation is one of the very, very important aspects for many things. What Pranjal says that.
Yeah. Dr. Sadhana, I just want to say something.
Yes,
that screening for preeclampsia you should do in the first trimester.
In the first trimester,
along with the
uterine artery.
Yes, uterine
artery.
Doppler.
No,
you can add low-dose aspirin at that time only.
Yes. It is, and it should be started before 16 weeks.
Before,
Around
16
weeks. Before 16 weeks. Preetam, but your takeaway, anybody, Dr. Sudha, Dr. Usha, that universal cervical length screening you wish, or you do the history indicated cervical cerclage or progesterone. So there is a lot of confusion about it, unnecessary cervical cerclage, and sometimes really we are having a frank cervical incompetence. So what is your takeaway in our low risk women, a large majority? Dr. Sudha and Dr. Usha.
Ma'am, routine cervical length measurement should be done when we are screening the fetus and when you are trying to detect high risk fetus. So when you are doing that, also at the same time also do cervical length assessment. And there is a very less role for cervical encerclage now. A simple use of progesterone as a uterine relaxant itself can prevent preterm labor. And detect if there is cause for preterm labor, there is an infection causing or an uterine anomaly.
Hello. Hello, am I?
I think madam's connectivity is Dr. Sudha,
Pranjal,
madam.
you can, Pranjal, you can. Dr. Deepika wanted to add something about this thing. So Pranjal, you can read out the carry home messages, because we are running like we have to finish in 2 or 3 minutes.
So what there are some professional bodies recommendations. All women, all pregnant women who are planning to pregnancy should have evaluation for risk factors for cervical insufficiency. Detailed evaluation of risk factors and previous history should be undertaken in women following first and second trimester loss, or early preterm delivery. This is level 1B. This recommendation in women with history of cervical insufficiency. Urine culture sensitivity is very, very important. Vaginal culture for bacterial vaginosis should be done at first obstetric visit and treated accordingly. This is level 1A recommendation. Women with history of 3 or more second trimester pregnancy loss where no specific cause other than potential cervical insufficiency is identified should be offered cervical encerclage in those women. Professional bodies doesn't recommend it. Routine encerclage not indicated in women on incidental finding of short cervix of less than 2. This is very important, of less than 2.5, because we have many a time we have seen that 2.5, the reading is 2.5 and that patient is going for postdatism. So therefore, this is a strong recommendation that these patients routinely should not be offered encerclage. Women with history of 1 spontaneous mid-trimester loss or preterm birth should be offered cervical encerclage after a good counseling. If transvaginal USG surveillance shows cervical length less than 2.5, less than 25 mm before 24 weeks of pregnancy, level A recommendation, and NUSG indicated cerclage not recommended for funneling of the cervix, or in that case, a rescue cerclage, the help of rescue cerclage is doubtful. This is level 2 recommendation.
So I think we have covered, and what Dr. Sudha has said around what we do, anomaly scan or the 14 to 20 week scan. Do look at the cervix. We can easily do it. Just we, like so many times it is not reported, and make it a practice, and we can have a certain level of idea. And the transvaginal sonography is a much better tool to detect the cervical length. And if you find something on abdominal, then you can go for the.
In preterm labor, the one thing is, during preterm labor, the one thing which can help is a early trimester scan. If someone picks up the anomalous uterus in early pregnancy scan, so that also give you indications or hints towards the preterm delivery of that patient. And in that case, we can offer her encerclage.
And what all the things say, it is not only cervical shortening, it is mostly it is infection and inflammation in our country actually that leads to premature leaking or premature preterm birth. Always look for the bacterial vaginosis, for the urine culture sensitivity. If it is there, treat them properly. So we are too much on progesterone and too much on cervical cerclage, and we tend to forego many which are much more common cause and which are much more hazardous to the baby also. So this is very important. I think we will be finishing. So just going like having emitting few questions. Dr. Manisha and Ritu, when there is a itching and a little bit rise of this thing, liver function test, what you say, you ignore it. How do you treat, and when you want to terminate? Dr. Manisha.
Madam, intrahepatic cholestasis of pregnancy is the cause most of the time. Then it is characterized by pruritus developing mostly in 3rd trimester, but it may start from 2nd trimester also, and it disappears after the delivery. Now, regarding the pathophysiology, it occurs due to the slowing of flow of bile, which leads to increase in the bile acids, and it affects the myometrial contractility and causing vasoconstriction. And this is the danger to the fetus mostly. And due to this, it's result in meconium staining of the liquor, sometimes fetal death, and IUD. And regarding the treatment, we can give antihistaminics, then topical emollient, because it is the most frustrating symptoms, that is itching. And the UDCA is the drug of choice, which also relieves the pruritus by decreasing the bile acid concentration. Then sometimes vitamin K deficiency also can occur. So monitoring of LFT and PT should be done, and NST should be done bi-weekly, and planning of delivery should also be done.
Excellently, Manisha.
Thank you very much.
Excellent.
So,
Dr. Vaishali, your take on vaccination quickly?
Very, very quick, because we are going to wind up. Very, very quick. COVID,
Dr. Vaishali?
everybody want to say. Vaishali, Dr. Usha, anybody can.
Hello, ma'am.
Hello,
Yes.
hello.
Yes, Vaishali.
Ma'am, nowadays we are not giving them TT. At least we can offer them TD even in the poor resource settings, because they are the cost is same. So at least instead of TT, we should give TD. And ma'am, flu vaccination and Tdap vaccination is recommended, and we are doing it routinely for all patients. After 27 or 28 weeks, we can give them. And ma'am,
what about COVID vaccination, Vaishali?
COVID vaccination is a must, and we are counseling all the patients that they must get COVID vaccination done, both the doses. And ma'am, patients are getting vaccinated after Foxy has given
endorsed
signal
the COVID vaccine.
Vaccination.
So COVID, very rightly say, so TT, all, it is a 3 TT, TD, tetanus and diphtheria, 2 or dose, and the Tdap pertussis is around 27 to 32, 36 weeks, though we can give any time. And flu shot, especially when the patient is having high risk, like thalassemia or any sickle cell. High risk, 100, like necessary flu shot should be given, and otherwise you can take according to your epidemiology, and COVID for all. So I think we will go adherent placenta. We are not taking pranjal because it will take much more time, but be aware of adherent placenta whenever there is previous operative delivery or hysteroscopy, myomectomy, something, and with the placenta previa, be careful that you are not.
Whenever with any reason you are putting a probe or doing the sonography, make sure that the placenta is not low lying and it is not adherent. So that will save your skin and will help to reduce the maternal morbidity as well at that time.
Yes, this is one of the life-threatening complication, and we don't want that we encounter placenta accreta at the operation table. So be very, very careful. Any placenta previa, especially anterior one with previous cesarean section, be ensured that it is adherent or not. And even if it is not like adherent, I will say be careful. Don't remove the placenta on the operation table. Let the placenta deliver on its own, because sometimes you really will end up in the unconfirmed placenta previa accreta. So this is very important. We will say last time, I think we can say growth scan. We will say we will go to the last your message, every panelist.
Everyone.
How do you, your message to optimize antenatal care, to optimize obstetrical outcome in our country? So one by one, all the panelists we will like to have your message from
Dr. Sudha, madam.
Ma'am, start it early. The antenatal care, start it early. Continue. All the advice that is given, get yourself and your child also screened. That should be the message. And also add during the counseling, the importance of contraception and spacing during the antenatal period only. That would be my message, ma'am. Thank you, ma'am.
Dr. Bharti, madam.
Every patient should be counseled, and not only the woman, but the whole family should be counseled. And second thing, each and every step should be taken to improve the status and health of the woman in the form of education, employment, and empowerment.
Yes, true. Very correctly said. Dr. Ritu, madam.
Yes, every patient should be taken with proper care, and every patient, we should form a relationship with every patient so that they also come up with the things very clearly. And I say that we should be very honest with the patient, and patient should also be honest with us. And accordingly, everything should be in detailed. All the investigation should be done, and the patient should be benefited for coming to a doctor.
Dr. Vaishali, madam. Thank you, Ritu, madam. Dr. Vaishali, your input.
Ma'am, first and foremost is women empowerment and education. Ma'am, that is the biggest thing. Then only they will understand whatever advice we are giving to them. And ma'am, women empowerment is very essential. And ma'am, from the even adolescent and preconceptional counseling, and ma'am, most important, family planning, everything, ma'am, they are all so mixed that it's a vicious circle. Everything is linked to each other.
Yes, true, Vaishali. Correctly said. Dr. Manisha?
Yes, I more emphasized on the history taking, madam, and preconceptional counseling so that we don't get surprise packages while we are treating the patient antenatally, intranatally, and postnatally. So proper history taking, counseling the patient about because we know every pregnancy is a low risk pregnancy if it is not associated with any disease, but if it is associated with any comorbidities or it, then we have to deal it with very cautiously, preciously, and consider as a high risk patient. This is my
perfect planning is a key factor. Dr. Manjula, madam?
Yeah, so all the panelists have so beautifully enumerated all the points. So I just wanted to highlight this issue that as obstetricians, I think we have the power to have an intergenerational effect. By that, I mean that if we take care of the mother appropriately during pregnancy, we give birth to a healthy child who grows up to be a healthy human being. So we have the power to influence 2 generations. So I think that is something we should keep in mind and follow what all our panelists have mentioned today.
So in your setup, always keep all the things ready, prepare for the worst and hope for the best. So the God will give you the best. At the end, I will take only one minute for Dr. Sadhna Gupta, madam. I am really very much impressed with so many good slides, madam, especially your Hippocratic quote on comforting away, and also your templates on high risk versus high risk mother and high risk fetus. So there were so many impressive messages, madam, you have given through your PPTs. So thank you very much for making me part of this panel, and I really thank you all the panelists for their wonderful inputs to this. I also am very much thankful to chairpersons. I am also thankful to Dr. Usha Sharma, Dr. Gangadharam Sahu, Dr. Radha Jinna madam, and Dr. Reena Srivastav madam. And last but not the least, Dr. Sadhna Gupta madam, there is a lot to learn under you. So I am enriched today. Thank you, ma'am.
Thank you, Pranjal. It was all your program. And what we say, teacher and disciple travel together on journey to search truth. And truth is ever changing in course of time. So we all are together, all the people who are in the faculty, who are joining us online, on Facebook, on YouTube, that we are always in search of truth, and we always have to hand together for this journey. Hearty thanks for joining journey. Happy Republic Day. And I see.
Thank you, madam. Madam, can I take 1 minute? Madam, can I?
Manisha, sure. Yeah.
Yes. At the outset, I would like to thank you, respected Dr. Sadhna Gupta madam and Dr. Pranjal Sharma madam for considering me and all the organizers and giving me the opportunity to interact with you all. At the outset also, myself, Dr. Manisha Ghate from Chandrapur, Maharashtra, would like you to request you to nominate, support, and vote for me from your societies for the FOXY chairperson elections for No to Violence Against Women Committee. I have been working for this cause at ground root level since so many years, not only helping and uplifting the women by health, but also taking care of their social issues and solving their problems ASAP. So again, I humbly request you, all the respected seniors and my dear friends, to please support and nominate me. Thank you so much, ma'am, for giving me the opportunity.
Sure. Yes, Reena, madam.
Thank you, Sadhna, for such a nice and wonderful panel. And thank you, Deepika, for your very nice, insightful message for fetal medicine reference. And I would like request to all of you that Sadhna is a very good candidate for presidentship, and she has worked a lot. We have seen her journey for the last 20 years, and her candidature is a very good candidature for presidentship. So I request all of you to please nominate and vote her for president this time.
Yes. I also would like to add that she is very, very academic oriented.
Yeah.
And it would be really wonderful. So I wish her all the best and request everyone also to vote for her. And ISOPARB, I'm sure, is going to be with you.
And Reena, for the opportunity.
Thank you.
I have one more word, dynamic and innovative to Sadhana's slides. Excellent presentation and involvement.
Yes.
Thank you for the opportunity. Thank you. Thank you.
Thank you. Thank you so much.
Thank you.
Thank you. Thank you.
Bye.
Thank you. Thank you.
Thank you, Sadhana.
Thank you, and please take care.
Thank you.
Thank you, academic partner.
Conclude
And all the best, Dr.
Aruna,
Sadhana.
are you
All the
there?
best for you.
मैं
All the
हूँ
best.
यहाँ पे.
So we request Aruna to
Dr.
close the
Gangadhar Sahu want to say
meeting
something.
formally.
I think Amrita, Dr. Gangadhar Sahu want to say something.
Yes, sir.
Yes. So once again, my best wishes to Sadhana madam. I hope her dreams will be fulfilled.
Thank
So,
you.
my opinion regarding this panel is that my take-home message. So normal pregnancy and normal labor is a misnomer. It is not normal unless it is completed normally and mother and the baby goes home. They go home in a healthy condition. So be a dedicated obstetrician. Let your touch overpower the text. So that is second thing. Unless that is in your brain or mind, it is very difficult to prescribe which are the investigations to be done. So minimum intervention and maximum benefit should be the aim of every obstetrician. Thank you, madam. Thank you.
Very rightly told, sir. Rightly told. Sir, obstetrics can turn out to be a catastrophe anytime.
Yes.
Yeah. True.
Thank you, sir, for wonderful insight. And Manisha, all the best to you. And
All the best to you, madam, also.
Thank you, thank you. Let us wish all the best to both of
Yes.
us.
All the best to both of you, madam. From our hearts, we are going to wish you.
Thank you so much, ma'am. Thank you. Need your blessings a lot.
So over to Babita. For
Conclude, karo, ma'am.
Are you there?
Aruna, yes.
Yeah, yeah. Good evening, everyone. I am here to spell out words of thanks to all those who made this webinar a sweet memory to carry home. From the depth of my heart, I thank our chief guest, Dr. Usha Sharma, ma'am, who graced us with her presence and also for her thought-provoking address. I would like to thank our guest of honor, Dr. Gangadhar, for all words of wisdom that radiated a source of energy within us. He mentioned Ma Durga. Thank you, sir, for being with us today. My heart fills with lots of gratitude and respect for our distinguished special guest and guest speaker, Dr. Deepika, for gracing the occasion by her valuable presence and also for enlightening us with her commendable talk on the subject. We are blessed to see two patients that was mentioned by ma'am, and also 90% malformation occurs with no risk, so every patient should be screened and life begins at preconception. Heartfelt thanks to our chairperson, Dr. Reena ma'am and Dr. Radha Jina ma'am, who are always a source of energy to us. I am running short of words to express my humble thanks to moderator, Dr. Sadhana and Dr. Pranjal. 9 months, 9 problem, 9 solution. They have indeed put best of their efforts to make this panel very interesting, knowledgeable, and clearing our concepts and enhancing and understanding pertaining to this 9 months problem. Sadhna ma'am, we really owe you a lot. Today, we had galaxy of very intelligent panelists, Dr. Sudha, Dr. Bharti, Dr. Manjula, Dr. Vaishali, Dr. Usha, Dr. Manisha, and Dr. Ritu. Some points in the panel which were discussed, I would like to highlight that folic acid for all, but methyl folate for only high risk. Every patient should be screened throughout the pregnancy, as any low risk pregnancy can turn into high risk. Hepatitis B discordant, in that case, vaccination to be done. And if HBe antigen positive, then at 28 to 32 weeks, tenofovir should be given. For Rh negative patient, anemia should be treated and blood should always be ready. For antenatal screening of anemia, not only hemoglobin but CBC should be advised. And if there is microcytic anemia and MCV is less than 80 or MCH less than 27 picogram, then thalassemia should be suspected, and only in that patient electrophoresis should be advised. For risk assessing for PIH patient, gestosis score should be done, and hypertensive patient with any organ involvement, then we should go for preeclampsia. And for preeclampsia screening, echocardiography of the patient should also be done. I thank Dr. Amrita and Babita for moderating the webinar so smoothly. And finally, the wonderful attendee who have turned up in such great number. Thank you so much for making a successful webinar. We are also grateful to the sponsoring pharma team. Once again, thank you all and a happy Republic Day to you all.
Wonderful. Wonderful, Aruna. You have summarized so well.
Bharat Mata ki Jai.
Jai Hind.
Thank you, Ajay and Vasu from Corona. They are bearing so much with me. Just that is like 6 or 7 days we thought that we should do, because there was Republic Day and many things. So thank you, Arvind and Vasu, for and Nisha for all the support. So,
So I think we can leave now.